Ryan Stanton here with ASEP Frontline, joined today by, we're actually going a little bit infectious disease, shocker, during COVID-19 during the 2020, as my daughter pointed out, with Dr. David Talan. We're spanning the United States today with me in Central Kentucky, Maria, who's proctoring our efforts in the center aspect of the country in Texas, and then David is way out on the West Coast enjoying likely some gorgeous weather right now. So, Dr. Talan, thanks for joining us here on the front line, and tell us a little bit about yourself and your focus of interest, which we're going to talk about today.
Sure, Ryan. I hope you call me Dave, and hi to all my friends out there in emergency medicine land. You want me to tell you about myself? Well, I'm approaching a COVID risk group, so let's put it that way. I've been at this a little while. I've had more of an academic career. I've planted myself at UCLA hospitals pretty much the whole time since my residency. And my background's a little bit unusual in that I trained in emergency medicine. That's my primary practice, but I'm also trained in infectious disease. And so my focus, my academic niche has sort of been that intersection of infectious disease and emergency care. Done that for some time, trying to look at just about everything that might become an issue to us. You know, whether it's diagnosing and treating meningitis, sepsis, you've looked at pyelonephritis. You may not remember a time when even a young woman came in with a high fever and a kidney infection, they were admitted to the hospital, but we looked at how we could manage patients as outpatients, done a lot of work in MRSA, took on that dogma that an abscess if it was open and drained, wouldn't benefit from adjunctive antibiotics. Turns out antibiotics actually improve outcomes. We've focused on bacterial resistance, most recently ESBL, gram-negative bacteria with urinary tract infections. And over the course of this, I've had a long-standing relationship with the U.S. Centers for Disease Control to direct a network of emergency departments to study aspects of emerging infectious diseases. We certainly have an emerged infectious disease right now with COVID-19.
Well, tell us about that, how that has, for you, with all the stuff you've done. You know, there's been important and big infections that we've dealt with, but now you've got probably the first really got its wheels in the United States worldwide pandemic, COVID-19. How have you approached and addressed that with your work in California and relationships with the CDC?
Actually, I'm quite involved in a very interesting project that has kept me quite busy. So I'll tell you a little bit about it. It's called the COVERED Project. COVERED stands for COVID-19 Evaluation of Risk to Emergency Departments. Although Dr. Fauci has done a great job sort of handling our response and the public's information about COVID-19, the real truth is there were no experts about this. This is something completely new. And so I've tried my best to educate myself, and the real experts are the people who just try to read as much as possible. So I did that, and I was exploring the question of what is our risk of acquiring this. Obviously, that's got to be one of the most important questions right now to our colleagues. And I came across a paper which studied healthcare worker risk at the time of the SARS epidemic, the part of it that went to Toronto, Canada. And one of those authors was a person I worked with at CDC. So I called them up and I said, we need to study this now, while this pandemic is going on, because the people I work with, they're very committed to taking care of patients, but they're absolutely concerned about their own safety. And if there's a way that we could understand what that risk is of doing our jobs and identify ways to reduce that risk, that would be very important. It certainly would be important to people I work with and important to the public who's so grateful for the work that we do. And so he replied, he said, this has become one of the CDC's most pressing and important priorities. And would you help us study this? So in the time frame of about 2.5, 3 weeks, we have put together a full prospective epidemiologic investigation. We've recruited 20 investigative sites across the country. In fact, the sort of site initiation call is later today. And we've obtained expedited funding from the federal government to do this. So they've really committed to our specialty. this has also kept me from being bored while I'm stuck at home if I'm not in the emergency department working shifts. So, wish us luck. I'm hoping that we can, really learn something from this. It is hopefully once in a lifetime opportunity. It's a funny way to state that, or at least this will help prepare us should we face something similar and as terrible in the future. So that's what I'm up to with regard to COVID.
And interestingly, the folks back, the 1918, 1919 Spanish flu, they probably didn't realize that some of the things that they did in terms of the isolation, separation, some of the trend lines and things would even be used as much as they have been over the last few weeks in terms of, our governor almost every day is showing the graphs comparing different cities. I think it's St. Louis and Philadelphia in terms of the cities and their trend lines and all of those things. And interestingly, this podcast, we were planning to do it well before any of this COVID stuff fluffed out. I thought, well, this seems like a great topic because we're hitting you up with infectious disease, but really at that point, initially the community acquired pneumonia, which is an incredibly common topic that we see, a presentation that we see in the emergency department. But right now it's even more complicated in the fact that we have for the most part, pulmonary disease that is presenting to our front doors and into our departments and looking into those different things, that differentiation, management, and even potentially ways to tell the difference. So let's talk about that a little bit, starting off with just the initial burden, the burden of community-acquired pneumonia and where we're seeing that, especially with us having a relatively aging population here in the U.S.
I think every emergency physician expects with the respiratory season to handle a lot of cases of community-acquired pneumonia. We certainly have an aging population. We have many more patients, immunocompromising drugs. Influenza vaccination is, people use it, but it's not completely effective. This concept of immunosenescence, so that people that need it the most don't get the most immune protection even when they do get vaccinated. And now, for some people are choosing not to vaccinate. So every year we have tens of thousands of influenza-related deaths. The most serious cases are going to come through the emergency department. And so now people forget, like before January 1st, before the 2020, our emergency departments, just like every year, were backed up with people waiting for admission, largely because of the impact of wintertime respiratory viruses, particularly the flu, right?
Mm-hmm.
And then now the flu has started to, being a seasonal disease, has started to disappear. In fact, it's pretty much gone right now across the United States. But just as the flu started to recede, of course, we were affected by the COVID-19 pandemic. So now there is a resurgence of patients with respiratory complaints. There's a change in how people choose to use the emergency department. I'd be interested if you're seeing that out in Kentucky. Like, we're kind of wondering, well, where did those folks with the MIs and the appendicitis go? Because they don't want to come to the hospital. They've been told maybe stay away from the hospital. And so are they staying at home? Are they contacting their doctors if they have serious complaints? We hope so. And now, of course, we're seeing more and more patients with more serious respiratory disease. And that raises this issue. Like one of the first questions I get is, well, if I see a patient and I diagnose COVID pneumonia, do I treat for community-acquired pneumonia related to bacterial disease?
And I know that's one of the things that always comes up with flu. One of the most common things that happens with flu in terms of more severe disease is the bacterial tag-along that comes along, and especially the MRSA that likes to get involved with it too. I did a radio program this morning. I do every Tuesday morning, start taping on a Tuesday. Every Tuesday morning here locally, Rise and Shine. So everybody in the central Kentucky area gets to hear me with morning voice, where it just hardly works, but it's okay. It's still information. And we were talking about it today in terms of the concern of the number of folks that are staying out and the fact that we're seeing late presentations of strokes and heart attacks and appendicitis. People coming in once it's already kind of gotten everything's already left the barn on that aspect. And so people are waiting until later. So the messaging today was, don't sit at home. Don't wait. If you got an emergency, you need to get in. We've actually had people, and we've talked to a number of them who've come in late, and they've actually said that they thought the emergency departments were closed to other emergencies. And so they weren't coming to the emergency department because they didn't think it was available to people other than COVID. So there's a lot of weird misinformation out there. And, returning the conversation back to the pneumonia standpoint, I think one of the big things that I think that a lot of us on the community side especially is that distinguishing between typical, atypical etiologies or a combination of both. And of course, now you're going to throw the curveball of a COVID-19 associated with the CT scan, crazy paving findings. Looking at those, what are some of the distinguishing characteristics between these typical and atypical there goes that word, etiologies?
You were a pro. You have your own morning radio station. I don't even know what I'm doing on here.
Because I've got 29 years on radio and TV. You have actual significant medical expertise. And so it's one of those things that I always heard, and I can't remember which president said it. It says, it's not about being the smartest person in the room. It's about finding the smartest people and letting them teach you about it or letting them do the talking. And so that's exactly what you're here for, is the fact that there is no way in 100 lifetimes that I'm going to catch up to what you've done and what you are doing with infectious disease, and especially this particular topic.
Well, thank you. I appreciate that. We'll keep working at it. Some of this is an old story, Ryan. Remember how we were taught there's typical bacterial pathogens that cause pneumonia? That'd be like pneumococcus. And then there'd be atypical ones like Legionella and chlamydia and mycoplasma. And, we were all sort of taught that a while ago. And then we were sort of untaught that. And we said, you cannot tell the difference. Although it's always preceded by, because I've written chapters like that. It always goes this way. It's like there's typicals, there's atypicals. The typicals tend to look like this. The atypicals tend to look like this. And then we'd like you to forget all that because we've tried to distinguish these clinically, and you can't do it. And the same thing with viral pneumonias too. We understand that a virus can cause pneumonia, and it can cause pneumonia without what we think any bacteria superinfection or co-infection. But that happens enough, and just like this attempt to distinguish typical from atypical bacterial etiologies, clinically it's impossible to tell. So, let's go through this again. So, bacterial pneumonia, you think of when there's an abrupt onset. Patients get sick. Maybe they're older and they have comorbidities. The X-rays, the sputum tends to be productive, right? And X-rays tend to look like lobar infiltrates, sometimes pleural-based. If you have a pleural effusion and an empyema, you're in business. That's a bacterial disease, right? Viral disease, and the same thing could be said for COVID-19, tends to not be as an acute onset. The cough is non-productive. The X-ray pattern looks bilateral, fluffy, not pleural-based, not consolidated. The laboratory, one of the things, tends to have less of an elevation of the total white count of neutrophils, more of a tendency to depress the total white blood cell count, and specifically in the case of COVID-19, have a relative lymphopenia, right? So in your mind, you could say, well, here's a young person. I think they have COVID-19. Maybe they have an epidemiologic risk. They've been exposed to someone in their household, or you're at a place where you can get the result back during care. And then you see pneumonia on the plain X-ray. Maybe you've done even a CT, and you're thinking do I need to give antibiotics? And I would say, I don't know, but before COVID, if we saw pneumonia, we would cover for the possibility of a bacterial infection. And certainly with the backdrop of this potentially, deadly progression in people of any age, right? But particularly older age groups. And, this might not be the time to be stingy with covering for bacterial disease. So that's sort of my conclusion. I think we're going to approach this the same way. Certainly, critical care societies have said, if you've got sick people in the hospital or in the ICU, we recommend also treating for bacterial pneumonia. And like most things in medicine, with regard to this specific question, there's no data, right? No data, no controlled studies. I don't think they're going to happen. The focus is going to be on therapeutics directly for COVID-19, and we're not going to worry about antibiotic side effects or, you might be so lucky to live long enough to get C. diff, right? So I kind of think that's how I would look at it. You could imagine if someone really wants to avoid antibiotics and you diagnose a healthy person with an early COVID-19 infection, I imagine you could avoid, you might not have to give them antibiotics, but I think mostly practitioners are going to. And then I would go to, and this is a transition to the latest IDSA ATS recommendations for treatment of community-acquired pneumonia.
I completely agree with this. I don't think we know with the COVID-19 and then who may tag along with it and the number of things are on there. You don't want to say this is strictly a viral illness on something that we're really just learning on the fly as we go, and then say, oh, well, on the back end say, oh, well, actually this particular bacteria likes to hang out with it as well. They like to be friends and do all those things. And we'll kind of work towards the approaches to these therapies and evaluation in the emergency department. And just first and foremost, though, with the question is whether you get the same issue that we have here locally, where people go into one of these box store type clinics or walk-in type places and somebody throws a little stethoscope on the chest and says, you've definitely got pneumonia, and then start them on some large cadre of antibiotics and send them out. And then they come to the emergency department because 4 or 5 days later, they're still feeling bad and not getting better. And of course, we get an imaging study, is completely clear. Come to find out, honestly, it's probably just more upper respiratory, whatever it may be anyway. I assume, or has California evolved past that point, or is it similar to here in Kentucky where we still get the whole stethoscope? You've definitely got pneumonia. Let's do that. And then if you don't get better in a few days, respond immediately to your local emergency department for a legitimate evaluation.
No, we do just the stupid things in California. Maybe more so. Sometimes we're credited with, pioneering, approaches that aren't quite correct. But yeah, I think that goes on. And maybe it goes on more, thinking about people wanting to stay away from hospitals, hospitals, doctors' offices. This is not the time to hang out waiting 3 hours for your appointment in the waiting room of your GP, right? There probably is more empirical treatment. You could understand that somewhat. And if there is going to be more empirical treatment, then there's probably going to be unnecessary treatment and unnecessary side effects. So I expect that we'll see that.
And we see all that, and it's with good fun. I understand the situation, folks. And of course, now you're going to see even more, because even like today, my wife is internal medicine pediatrics physician, and her clinics today are telehealth related. And so even that limits that evaluation even more. Like David, get close to the camera and open your mouth really big. Now I need you to move this way and just have the sunlight come through the window just right so you can see the back of your throat.
Maybe there could be like a stethoscope app and connection that you could put on a cell phone. You could have people just, put the thing or the transducer or maybe the phone itself, like all around their lungs and listen to their lung sounds.
Well, at least at this point now, and I know what the innovation side of emergency medicine is going to say, well, why don't we just send everybody an ultrasound machine and have them put them on there, and then we can see it online and say, oh, there's the beeline.
That's true. There's adaptations for ultrasound. Yeah, anyhow, we're getting far afield here from pneumonia, I think.
Yeah, we are moving quite a bit off the topic, but that's part of the conversations. Once you get isolated for long enough, the conversations do tend to wander because you have plenty of time to consider said conversations. When we have these folks come to the emergency department, though, so we're finally in person now, and folks come in. Get us through some of the focus, history, and physical associated with these types of presentations and recommendation in terms of things we need to do when face-to-face with these patients.
I think these days, specifically, the epidemiology is pretty important. You want to know what their potential risk is for COVID-19 in particular. But, you're trying to determine the risk of someone having a bad outcome. So the past history, comorbidities, immunosuppressing drugs. I'm kind of worried about MABs. So many people now are on MABs. Mm-hmm. And, it's not exactly like having profound neutropenia or advanced HIV, but there is something immunosuppressing about all of them. And yes, they're associated with some weird things like recurrence of tuberculosis or fungal infections or reactivation of hepatitis B. But you also see some increased susceptibility to bacterial infections as well. Not to a super high degree, but I think emergency physicians, we need to sort of note those and maybe give an extra point towards concern for a patient on a MAB. And then many of the historical findings that we covered before in trying to distinguish sort of viral, atypical, and standard bacterial infections, although I think we've sort of abandoned the idea that we could distinguish those very well. I think the living situation is pretty important now because of contagiousness. Mm-hmm. If you've got somebody who comes from a long-term care facility, there's real implications to, what their diagnosis is and the safety of the people in that facility that we never had to consider before COVID-19, right? Then you can get lost in the weeds with sort of these, very rare types of pneumonias that maybe are also associated with outbreaks like Legionella. But in a way, when it comes to diagnostics and therapeutics, it's pretty straightforward. You can evaluate someone. If they're not that sick, you can use clinical evaluation to determine if they have pneumonia. If you're thinking that they have bronchitis and they don't have pneumonia, then I think everybody should pause and say, okay, let's make sure, because we don't want to miss an early bacterial pneumonia. So it's not to say you need to get an X-ray on everybody with a cough, but if somebody's older, compromised, has comorbidities, obese, if their pulse ox isn't quite where it should be, or the respiratory rate's a little higher, or if they have bronchitis symptoms, but they have a lot of chest pain, especially with breathing in, like that could be a pleural-based pneumonia. Mm-hmm. So I'm always worried about sending somebody home with a pat on the back without antibiotics who have those characteristics where I have not ruled out pneumonia with an X-ray. So I think those groups are the types of groups you're going to want to do an investigation. Others you can say, no, sounds like a typical URI, you don't need antibiotics. And others you may feel comfortable diagnosing pneumonia clinically and starting them on antibiotics. Laboratory testing, not so important in most cases, but I think as you get to a sicker group, you'll find that some of the X-ray laboratory abnormalities can inform whether or not there's sepsis, organ failures, and what type of prognosis the patient will have in the short term and what level of care they might need should they be admitted to the hospital.
One of the bigger things that the challenges that I've at least locally, I feel like we face is that we have folks that have come in that have these viral syndromes. Of course, in December and January here, we saw a ton of RSV in the elderly population, and not just the typical kids that we would see. And of course, they would come in the emergency department after 3 and 4 weeks of feeling bad, cough, some shortness of breath, having 2 and 3 rounds of antibiotics. And of course, eventually the elderly person ends up on one of the fluoroquinolones, which is, just waiting for that Achilles to wrap up like a cartoon. And with those, and this virus with COVID-19, it seems very similar in that it just limps along for so long that most people will end up with a couple of rounds of antibiotics and a couple of different things and eventually land on that emergency department. More often than not, a lot of times you've had antibiotics that have killed this thing. I mean, it could have killed any type of bacteria you'd had in you unless you've got something really funky, and I don't have anything else for that. And then our imaging studies don't show anything new or exciting. Are we seeing, is this year just a special year for these pulmonary infections and processes that are just limping along for so long that people are getting a lot of rounds of antibiotics? Because that's going to actually get to the next question about resistance. Does this year special, or is this just something that, other than COVID-19, that is special? That's once in a lifetime, once in a generation. That's special. But even before COVID-19, it seemed like that we were seeing a lot more of these illnesses that were just the bronchiolitic type aspects that were just limping along for weeks and weeks compared to what we'd seen in the past.
No, I don't know. I don't notice a big change. There's always those patients, and you tend to remember them. And there is this sort of funny thing, like when you work as an emergency physician, we're always sort of like victims of Monday morning quarterbacking a little bit. Like, you'll treat somebody appropriately, you'll diagnose their pneumonia, you'll give them the right drug, and then, they'll follow up with their primary care doctor. And even though like their energy is back, their appetite is back, their fever's gone, the lungs take some time to repair. So they'll still be coughing. And then the GP will go, oh, that emergency department treatment, they didn't give you a strong enough antibiotic. And so they'll give them another antibiotic when, of course, they don't need it. They just need reassurance. I don't think we're going to solve that problem. And I do think this particular situation is going to lead to more empirical prescribing. Patients are also insecure. I'm insecure. You're insecure. Like, this can kill you. So, if any time patients needed to feel like they were doing something active to get themselves better, it'd probably be now more than before, right? So I would expect to see a lot more antibiotic use for respiratory illness, even though there's no good evidence that any of the standard drugs are particularly effective against COVID-19.
Patients need I remember back in 2009-10, the hospital where I worked got rid of the flu test because of the cross-reactivity with H1N1, with strep and things like that. They said, we just don't need to test anymore. And so the same thing with this, with COVID-19, folks say, well, why do we need to test mild patients or people with minor disease? We're going to end up sending home. And talking with them like, well, humans feed on having information. And, it's amazing how having a relatively definitive diagnosis really changes people's expectation or course. You can say, okay, this is RSV. This is how long you can expect for this to happen. And of course, the more recent real-time tests and that's probably why I've noticed it this year more than any other years, we actually had the availability of the real-time tests that could come back in an hour or two with our viral panels. So we identified a lot of these things versus what we were doing in the past, which is just that kind of clinical and presumptive treatments. But there's a huge value to patients and to even healthcare of knowing exactly what you're seeing, the patterns of what you're seeing. And so to the point that with this RSV spike in December, after a week or two, we were able to identify them as soon as they walked in the door and say, you've got RSV. This is what's going to happen. This is what you can expect. This is what I'm going to see on imaging study. This is where things are going to go from here. And the patients seem to tolerate it pretty well. But going back to the question, from before, talking about these prolonged illnesses, multiple rounds of antibiotics, we already knew that our stewardship for antibiotics in this country and worldwide was not ideal, if not downright paltry / offensive, with the use of antibiotics for anything and everything. The discussion of antimicrobial resistance is becoming a legit concern in terms of us really emboldening these bacteria to select out the strongest and the most resistant of these types of things. Where are we right now in the horizon of antimicrobial resistance when we don't seem to be having as many antibiotics created as we're burning out?
I mean, with respiratory illnesses, we've seen pneumococcus acquire resistance to macrolides. And, it's interesting that azithromycin has emerged as one of the candidate sort of drugs for cocktails to treat COVID-19, when I think many doctors have sort of relegated it to this is a nice placebo that'll satisfy my patient and get them out of here. They ask for Z-Pak, right? The real killers in pneumonia, the main killer to the typical patient is strep pneumo. Pneumococcus. And yes, you've probably seen cases of staph pneumonia, MRSA pneumonia. It's not to say that's the only one that can kill you, but in terms of what the general population, what the typical patient with severe pneumonia has to worry about, it's pneumococcus. And the fact that pneumococcus is no longer, consistently susceptible to, one of our very well tolerated, popular antibiotics, azithromycin, becomes a problem. And then the next thing is it's not only antibiotic resistance, it's human resistance to side effects of antibiotics. Fluoroquinolones, super great drugs, like best drugs for urinary tract infections, or they were, right? Mm-hmm. And they were very helpful drugs for pneumonia and still are pretty active against the serious typical, atypical pathogens. But what we've seen with fluoroquinolones is that, and it began to appreciate, maybe 5-10 years ago, is that there are some very serious side effects associated with fluoroquinolones. You mentioned tendon rupture, but fluoroquinolones are number one on the list of culprits to promote C. diff, which is a huge problem. They're associated with hypoglycemia, peripheral neuropathy. The latest thing, speaking of tendons and connective tissue, is they are actually associated with a risk of aortic dissection. So, and there are drugs you should use in pregnancy and on it goes. So the Food and Drug Administration said, like, stop giving fluoroquinolones unless you have specific indications where you need to give those drugs. And one of the real changes with pneumonia guidelines was for IDSA and ATS to move away from fluoroquinolones as primary recommended antibiotics for your higher risk outpatient and your inpatient admitted pneumonia patients.
And the whole fluoroquinolones. For some reason, the whole idea of the side effects just make me think about that whole cartoon where something pops and breaks and like an whole screen. And that's what I tell all my little old ladies about. Like, can I get some of that Levaquin? You are 98. Let's stay away from that. But we have to make a decision. In the emergency department, the key to emergency medicine is we are basically the air traffic control of healthcare, and we're to get you when and where you need to be. And so we have to make that decision for our pneumonias at some point on outpatient versus observation versus inpatient treatment. What are some of the tips and keys to really kind of make that decision on the fly as we face not only this, but also the return of volume and that I'm sure will come in and then hopefully return more to a typical pattern coming up over the next few months?
This is something that's evolved like over the course of my career. I was telling you how, when I started, we would admit any sick, febrile young woman with an uncomplicated kidney infection. Now we give them some fluid and bring their temperature down and some antibiotics. We shake them around, and in a couple hours, they defervesce and give them something to drink or eat, and they suddenly realize like they feel well enough to go home. That's pretty amazing. Like, we take that for granted now, but we used to fill up hospitals with those patients. And same thing with pneumonia. If an adult had pneumonia, that was an admittable diagnosis, right? And then through some good work, few years ago, we created scoring systems and identified that actually the vast majority of adults with pneumonia could be treated as outpatients. And I don't know how many of us actually go into MedCalc and put in the pneumonia severity index score or things like that, or we're just familiar with it. And we're somewhat emboldened by knowing that many patients can start out as an outpatient. You could have their PCPs follow them if possible, and they do fine. So, if you want to use those scores, they're helpful. Sometimes I like, if I have a patient and I want to buff the chart a little bit and justify that they're going home, maybe I'll give them a shot of a long-acting antibiotic like Herceptin. I'll put in the score and I'll say, this fellow's low risk. I've talked with him about the risk and benefits of hospitalization. He's going to give it a try at home, and I've contacted his continuing care doctor. You're all set. So those types of scoring systems, can be used, and they can be really helpful.
We've seen a ton of evolution recently and a lot of tools and studies out there on how many things that we actually admit to the hospital, like the syncope patients and things like that actually can do just fine at home, that we're not doing any value added other than basically a comfort blanket for us to admit somebody to say, well, even if there's a bad outcome, I admitted them to the hospital, understanding that there's a certain percentage that aren't going to do well either way, no matter what the diagnosis is, and getting down to the nuts and bolts of whether the admission to the hospital is actually going to provide benefit to the patient in terms of outcomes and recovery. And we've already talked a little bit here about some of the treatments, and that's an important kind of final discussion when it comes to community-acquired pneumonia, because we've talked about some of the antimicrobial resistance. We've talked about some of the macrolides, the azithromycin, the official antibiotic of viral illnesses, and things like that. That the Levaquin or the fluoroquinolones getting pulled from a lot of the first-line treatment algorithms. Where are we right now with that start-off point, the jump-off point for our community-acquired pneumonia management and treatment?
Yeah, okay. So I think the first big change with the new guidelines for treatment is to substitute high-dose amoxicillin for azithromycin for your healthier, not so ill patients with community-acquired pneumonia, where you're going to cover for bacterial disease. High-dose amoxicillin is specifically recommended and in high dose to treat for the possibility of pneumococcal infection. And so I guess the thing to remember is it's well tolerated. we sort of stopped using amoxicillin for a lot of things, but it's a gram TID, that, the higher doses. Mm-hmm. So that can be your substitute for azithromycin. You might go, well, it's not once a day. No, it's not as convenient. The recommended duration can be as short as 5 days. Mostly people would prescribe at 7, and then maybe advise the patient, hey, look, once you defervesce and you're feeling good for maybe another 24, 48 hours, you can stop. And then for the not so healthy outpatients, the switch has been away from fluoroquinolones to recommend now dual antibiotics such as high-dose amoxicillin clavulanate, Augmentin, and we're talking about daily doses of like 1,500 to 2,000 milligrams of the amoxicillin part, right, with azithromycin. So that's 2 drugs that patients have to take. There's some newer drugs which we're going to talk about, lefamulin and amaticycline. These are oral drugs. They are single drugs that can be taken. Lefamulin is a drug that it's called a plural mutilin. Sounds like something pretty powerful to me, but it acts at the ribosome, and it's a twice-a-day drug, and it gets typicals and atypicals. So it's a newer drug. So as opposed to generic drugs, there's going to be an extra cost, but it does offer some convenience as a single drug, oral drug that you could use as an outpatient. It's recommended as a 5-day course. It was compared against moxifloxacin with or without linezolid, and it held up well in non-inferiority studies. So last year was FDA approved. And the things that practitioners should know about it is that it can prolong QT. So you have to watch out for patients who have that history or on drugs that are potentially QT prolonging. And it has some drug interactions that are more complicated than I can explain here, but they involve cytochrome system. And so this is a drug where you may want to talk with your pharmacist or make sure that you check the patient's med list for potential drug interactions. But otherwise, very well tolerated drug, and it's new. And then the other one that's new is a drug called amaticycline, which also works at the ribosome. It's a tetracycline derivative with the same types of, sort of cautions, contraindications about teeth staining. And actually, both these drugs should be avoided in pregnancy. It is a once-a-day drug. Probably the one thing to know about it is it has a fairly significant rate of GI upset, the oral form. So that would be something to think about. It can also be used as a single agent as opposed to now this IDSA recommended combination treatment. And both of those drugs are IV too. So they would lend themselves to practices where you'd like to start an IV and then continue the same drug orally. So that's a little segue, that's a little detour into some of the newer agents that could be used outpatient instead of dual therapy with Augmentin and azithromycin. And then the last thing I'll say is that for IV therapy, really nothing's changed about the recommendations, other than those 2 new agents that could be used now as single agents. We're still talking about, Rocephin and azithromycin for most patients whom you admit. And now guidelines are sort of de-emphasizing this categorization of HCAP, where we treat anybody exposed to an antibiotic or who walk through a hospital for an hour to be treated empirically for MRSA and Pseudomonas. So kind of moving away from that, keeping with sort of this standard advanced generation cephalosporin with a macrolide. And that's what I got.
And you're done. Ready for a COVID nap. I'll be looking forward to. I think this year is the year that IMRA updates they're kind of ongoing, but I think this is the upcoming year for the update of the. I was looking at the community acquired pneumonia recommendations with the IMRA antibiotic guide, looking at a lot of these things, and this is the year. I think it's a Q2 year rotation on getting the kind of the major update. And Always Eats was always one of my favorite interviews. I think our last discussion was actually in your part of the world. We were at ACEP 18 in San Diego when we had our last discussion about the IMRA antibiotic guide and update. And I think that's important to understand, that we have this evolution. And one of the hardest things for physicians is that kind of continuing update in practice. We seem to, especially us in the community side, we kind of get locked into our plans, our treatments, our routines, and carry those through our entire career. And the management of community-acquired pneumonia, not only because of resistance, new medications, safety, associated issues is evolving, and we need to make sure that we're up to date. And of course, working with your hospital on what the formulary is going to have involved, and then looking at the costs and things for your patients. I mean, I always tell my patients, and when I do things, the only time I know what type of insurance you have is when I'm trying to prescribe the medications for your trip home to make sure that it's something and things that you're going to be able to get. So I'm talking with Dr. Dave Talan. He's hanging out in California right now. He's keeping a good check on the West Coast for us. I'll keep an eye on the East Coast. And we got Maria that's going to keep the center in line. Give us kind of any closing thoughts as we discuss community-acquired pneumonia in the world of COVID-19 in the emergency department.
My thoughts are to everybody to hang in there. This is a pretty stressful time. You shouldn't worry too much about treating community-acquired pneumonia. That's easy right now compared to the issues that we have to deal with. I think it's hard to be just a human being now. It's depressing. We don't know when this is going to end. We're not seeing our friends and families like we used to, and work for emergency practitioners adds an additional level of stress, right? But people really need us. It's good to have a reminder about pneumonia now. Obviously, we're going to see more of this with COVID-19. So it's important for everybody to understand the latest recommendations on what types of drugs to use. Like you say, we sort of get stuck in a rut. We learn things one way and then, we forget to keep up. There's a few changes here. I mean, pretty significant changes in terms of what's recommended for antibiotic treatment. And I'm not just talking about new drugs coming on, but even some of the standard drugs we're tending to move away from azithromycin, away from fluoroquinolones, where, what do we do that for 15 years straight? Those were the drugs we relied upon. So thank you for having me. It's nice, even though this is a difficult time, it's a good time to talk about pneumonia, right? We're going to be thinking about this a lot as we all try to get through this.
As for a while, it felt like for a while that we had been kind of in a desert of antimicrobial therapies. And over the last few years, we've seen kind of a growth in newer options, whether it be for, abscesses, MRSA, community-acquired pneumonia, things like that. We're seeing new things out there. With a lot of the restrictions and things out there, it's harder for us as physicians, PAs, NPs, to know about the new things that are out there. We're not seeing those being hit upon us. These medications aren't necessarily the sexy ads on TV that are making people come in and ask specifically for a particular medication. So doing the research on them, seeing what's out there, see what the current recommendations are, staying up to date as possible on the current trends, management of community-acquired pneumonia or whatever the treatment may be. I mean, you had even mentioned earlier in the podcast with the antibiotics for the after abscess drainage. And so for so long, that was an absolute. You were an idiot if you gave antibiotics after you drained an abscess. It was completely unnecessary. But of course, you experienced and I experienced it as well, being in that initial kind of push of seeing a lot of these abscesses and trying to hammer them with antibiotics first without draining them, and then coming up with my rule for emergency medicine that if anybody says they can fix a skin abscess without draining it, you're just immediately to smack them in the face and get to draining it. But now coming full circle once again. And that's one of the nicest things about kind of the stage of the information era that we live right now, is that so much of this data gets out so much faster, that it can be translated so much faster and either is supported or debunked relatively quickly. We're seeing that with a lot of this COVID-19 information. And I do encourage everybody to look into these medications, recommendations, and things like that. Do your own research. Look at the data supporting these types of things, because remember, the first medication that was thought to be that was going to be a treatment for COVID-19 was literally, and I couldn't believe it actually made any news, was an N of 1. They had treated one person in China with this medication and then said it's a likely treatment for COVID-19 because they got better. So, just be aware, do your research, look into these things, keep up to date with the current management options and recommendations. We've got experts out there like Dr. Talan who dedicate their work to this, and we'll let them do the work, and then we'll just read the results of that work and help guiding us to do better by our patients, to manage them better for better outcomes and better safety. So, Dr. Talan, how can folks get in touch with you if they have any questions, thoughts, or comments about this episode?
Yeah, they can. You can email me if you want, dtalon@ucla.edu, and I'd be happy to hear from anybody out there. So thank you, Ryan, again, and ACEP for putting this together. I'll be happy to visit with you anytime again. Let me know, or visit you in Lexington, Kentucky, and pick up another course.
Yeah, we've got plenty. We've got a bunch. I've got behind my house right now is Ramsey Farm, and they've got a lot of them that they will charge you a lot of money if you'd like to take off their hands. So, feel free to visit anytime. That's one thing we didn't talk about on here was the fact that Dr. Talan does have some horse interest. In fact, interestingly, all three of the people on this call have a horse interest of some sort. I'm living in horse country right now. I do not personally own horses. Dr. Talan, with his connections through his wife, and then Maria through growing up with horses. So that's a common thread. So if you want to be on the podcast, get into horses, and we'll get you right on board here and get a topic of your interest. As for me, you can contact me at youreverydaymedicine@gmail.com, youreverydaymedicine@gmail.com, or at everydaymed on Twitter. I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.